everybody, and welcome to a brief discussion and demonstration of chest tubes and the use of chest drainage units that nurses are responsible for in the clinical area. So first I would like to introduce you to the actual chest tube. So chest tubes usually come in containers that look like this. They are labeled with the size of the catheter. The one that I have here is a 20 French. They are referred to as a trocar catheter. So when you take the chest tube out of its container, you'll see that the chest tube has sort of a metal rod that is on the inside. So I'm going to take these two pieces apart from one another, and this is actually known as the trocar, right? This metal piece that is here. And it has a pretty pointy end on it, and that enables it to be pushed through and get into the pleural space. Once the tube is in place, okay, it's placed with the plastic sheath on the outside. Once it is in place, then this trocar is removed and we have the actual tube that is flexible, that is left in the chest wall. So it is this plastic tube that's used to drain fluid or air from the chest that collects in the space between the lungs and the chest wall, and that's of course called the pleural space. It can cause lungs to collapse, right? So if there's something taking up space where the lung would normally be, then the lung is going to shrink in its size and in essence collapse. Chest tubes come in a variety of sizes and shapes. This one, as I said, happens to be a 20 French. And depending upon really what they're going to be used for is going to determine the diameter. The diameter and the size of the chest tube is not something that the nurse makes the decision about. That would be made by the provider who is actually putting the chest tube in. Now this chest tube is going to be connected to a drainage system, which we're going to get to in a minute, and that either collects the fluid or allows air to escape from the chest so that that lung can then re-expand, right? These systems can be allowed to basically drain passively or via gravity, or they can have suction applied to them. And in the lab, you're going to see some examples of that as well. Now, when these chest tubes are placed, generally the patient is awake, although they can be placed during a surgical procedure as well. But if they're placed at the bedside, the patient is awake and some local anesthetic is used and maybe some medications to help ease anxiety and deal with any of the pain. The discomfort of putting the tube in is generally temporary, so that once the tube is in place, patients really don't complain of pain too much. It hurts going in and then it hurts on the way out when it is removed as well. Oftentimes when the tube is placed, patients may actually feel that collapsed lungs starting to re-expand. Immediately after chest tube placement, a chest x-ray is done, and that chest x-ray is to see basically how much air or fluid has been drained, how much the lung has re-expanded, and of course to make sure that the final position of the chest tube is accurate, right? That it is where it needs to be. There are some risks certainly to having chest tubes placed. One of them is actually further collapse of the lung, right? Some other things certainly would include bleeding and infection, right? So these tubes are always placed under sterile technique, right? Strict sterile environment to put these tubes in. There are also some major risks, but they're very, very small, but that could include damage to the lungs themselves and maybe even the heart, right? Because all of them sort of sit in the same space. When chest tubes are going to be removed, one of the really important things is to ask the patient to take a deep breath in and hold it while a tube is being removed. And why is that? Because what we're doing is trying to equalize the pressure within the chest cavity and the atmosphere, right? We know that the chest cavity is under negative pressure, whereas atmospheric pressure is positive. So whenever you have a hole in the chest, air is going to rush in. And again, that air takes up space where the lung would normally have space to inflate, right? So it causes what we call a pneumothorax. Patients can also have collection of fluid, as I mentioned. Sometimes it's blood, and we refer to it as a hemothorax. Sometimes it's lymphatic fluid, and that's referred to as a chylothorax. When patients have a bad infection, where pus might be collecting in that pleural space, we actually call it an empyema. So those are some terms that you should be familiar with when it comes to the uses and the indications for the placement of a chest tube. The other thing that I wanted to mention, of course, is the nursing care that is related to patients who have chest tubes. Now, as I just mentioned to you, if somebody has a hole in their chest, right, that means that air can go in. So it is very important to make sure that the area where the chest tube has gone in has a good seal around it, because we don't want an air leak. So we usually use a petroleum-based gauze, which is kind of a little slimy and sticky, to wrap around that insertion site to make sure that we have a good occlusive dressing that's going to prevent any air from getting into that pleural space. So other things that you have to manage is going to be in relation to the chest drainage unit. So I have a chest drainage unit here, and I want to show it to you. And I'm hoping that you have already listened to the pre-voice thread for these videos for the respiratory lab, so that you know, because I'm not going to go over every single detail related to this, but I want to kind of show you what these chest drainage units look like. So first and foremost, we do have a lot of tubing here. So let me sort of try to detangle some of this tubing so that we can kind of get a better idea of what we're talking about here. So we're going to have basically two sets of tubing. We're going to have one set of tubing that is going to be connected to the actual chest tube that's in the patient's chest. And then we are going to have some tubing that is going to get hooked up to suction if suction is indeed ordered for this particular patient. So let's take a look here at the first part, which would be the tubing that is connected to the actual patient and to their chest tube. So when we are looking at these devices, I want to make sure that you are indeed seeing all of the components, okay? So I'll do my best to make sure that everything is in the picture. So first and foremost, this portion here is the actual chest tube. You'll notice that the tubing has markings on it, right, for centimeters. That tells you how far the tube is into the patient's chest, and that would be something to assess, right, to make sure that that tube is not migrating in or migrating out of the patient. These tubes are usually sutured in place at the level of the skin so that they do not move. Then we have a connection here. So this connection is going to tubing, okay, again, the tubing is long, is going to tubing that is going to be connected to our chest drainage unit. And you can see I have a little bit of drainage in there, all right? So this tubing is connected to the section of the chest drainage unit that collects all of the secretions that are coming out of the patient, right? Particularly those patients with a hemothorax, we expect to see drainage of blood and serous material into this chamber. So these chest drainage units, also known as a pleurovac, these are divided into three sections. It might not be apparent to you right now, but they're divided into three sections. So that first section, which is the section right here, is where this tube from the patient is draining into the drainage section, which is this section right here. You'll also notice that there is a clamp on this chest tube. It's called a slide clamp because it slides across the tubing to either, maybe it slides. It slides across the tubing so that the tubing is open, or again slides back the other way so that the tubing can be closed. Now, even though I just showed you this clamp, I want to tell you something very important. We never ever clamp chest tubes. Why do we never clamp chest tubes? Because it could actually cause a pneumothorax in a patient, something called the tension pneumothorax, okay? So we never clamp chest tubes unless we are specifically ordered to do so by a provider, right? And that's an important point, and the reason why I'm emphasizing it so much is, of course, it can do damage to the patient, but the other reason is that years ago, we used to clamp chest tubes routinely, but now we know that we should never clamp a chest tube. Okay, so that's our really first section of this chest drainage unit. And so what does that mean? Well, it means that we are going to be recording the drainage in here. And the way that this fills up, if you could see over here, okay, we start off basically at 0. And then there are increments, okay? And initially the increments are in increments of 10, right? And then they start changing to increments of 20. And then if the drainage reaches all the way up here at the 200, the fluid is now going to flip over into this chamber and start filling from the bottom. And now we see that the increments are getting bigger, right? The increments are in hundreds at this point. If they fill up this entire column, again, the fluid now will move over into this third column, and this third column, again, still in increments of 100. Maybe I'll use my other hand since I seem to have difficulty doing this. This is going to be moving in increments of 100, and you can see that this chest tube, the drainage portion, is going to be able to hold 2,000 milliliters of drainage. Once this gets full, then this whole chest drainage unit has to be changed. We do not empty them, okay? We don't empty them. So it can hold 2,000 milliliters of fluid. All right, so how are we going to keep track of it? Well, you're going to have a pen, okay, and you're going to make a notation right on this actual Pleurovac. So let's say that for your shift, okay, let's say that it drained 30 milliliters, all right? So I'm going to put a date here. I'll put September 10th, and I'm going to put a time. I'll put 10 a.m., okay? So I have made my markings right there, okay, September 10th at 10 a.m. for 30 milliliters. Now the next nurse comes after me, the next shift, and that nurse makes a mark up here at 90, okay, and does the time and says, let's say it's now September 11th and it's 8 a.m., okay, so you can see where the marking is made here. So that's how we mark with the date and the time the amount of drainage for a particular period of time. So I said that we were kind of marking it every shift, but please note that you could be marking it every hour, right? If a patient just had chest surgery and they have one of these chest tube drainage units in the chest tube, you have to keep track of that drainage because an increase of drainage in the immediate postoperative period could let us know that the patient might be internally bleeding, right? So you might be checking this drainage much more frequently. All right, let's talk about two of the other chambers. So the next chamber that I want to talk about is labeled here as B. Don't memorize it as B because all these devices, depending upon the manufacturer, they're going to, have different markings up here. But we're going to look at this section here, which is what is referred to as the water seal. okay, the water seal. The water seal is about keeping an intact system. So in other words, this chest tube in the patient connected to this device all has to be a closed system. There cannot be any leaks in this system. So how do we know if there's a leak? Well, we would see differences in the water seal. In the water seal, we would see bubbling, and bubbling would be considered an abnormality. What we want to see initially when the chest tube is first placed in the water seal is what we call titling. We see the fluid kind of going up and down with the patient's respiration. As the longer they have the chest tube, the more that titling will actually disappear, because as the pleural space is healing, in other words, the air is being removed or the fluid is being removed, we're going to see less and less movement in that water seal. But in that water seal chamber, we absolutely do not want to see bubbling, because then that tells us that somewhere in our system, either in the patient, in the chest tube itself, or in this drainage unit, there is a leak. And we need to kind of investigate where is that leak. So the water seal, you can see a marking right here, okay? So basically up at the top here, on the top of this thing, there is a little port, and we can add water to the water seal up to this level. They want it at the 0, okay? And this again is where we're going to be looking for that bubbling or that titling, all right? So that's the water seal. That tells us again that our system is intact or it's not intact. Then lastly, this column here is for suction. So this column right here is for suction. So we have another set of tubing, and that would be the tubing on this side. Remember, this tubing is the drainage tubing that is connected directly to the patient. And now on this side, we have tubing that is connected, let me just grab it here, that is connected to suction tubing. And that suction tubing, so this is all of our tubing, that suction tubing, the end of this is going to get connected to a suction machine, whether that is in-wall suction over the patient's bed on the wall, there might be suction set up there, or it could be connected to a portable suction machine. So here is a very, very important thing to remember about the suction. So when we have suction, we can either have wet suction or we can have dry suction. This particular chest drainage unit is a wet suction system. I do not have a sample of a dry suction system to show you, but just note that with this wet system, it's kind of more commonly used, and we are going to be responsible for maintaining the amount of water that is in the suction chamber in order for the suction to be effective. So our provider gives us an order that says chest tube to 20 centimeters of water suction. 20 centimeters of water suction is the most common amount of suction that is used for chest tubes. Could it be more? Yes. Could it be less? Yes. But 20 is usually the standard. So that's the order that you're going to see. So how do we get 20 centimeters of water suction? So you might be thinking, well, I'm going to make an adjustment on my wall suction, or I'm going to make an adjustment on my portable suction. Neither of those are true. The way that we control the amount of suction that is being applied to the chest tube is through the amount of water that is within this chamber. So you'll notice here that here is a blue arrow with a dotted line going to 20. And then we have another blue spot that says 15, another blue spot that says 10, another blue spot that says 5, and then we have increments all in between. Again, at the top of the drainage device, there is a plug here. We're going to open that plug, and we're going to take some sterile normal saline, not water, sterile normal saline, and we are going to fill up this suction chamber all the way to whatever the prescriber orders. And most likely, again, it's going to be this 20. So we're going to fill up through here with some sterile saline, and we're going to fill this up to the 20. And then we know that we are now providing that 20 centimeters of water suction. Now here's something to think about with the suction. When you have the suction on the wall or the portable suction, and you have your 20 centimeters of water in this chamber, and you turn on your suction, what you expect to see would be bubbling in this chamber. So bubbling in the suction chamber is good. Bubbling in the water seal is not good. So we have this bubbling. So I want you to just think, logically, what happens to bubbling water? If you bubble water, think about boiling water, what happens to the water? The water disappears, right? It evaporates. So one of the things that you're responsible for as the nurse is to make sure that this water suction stays with the right amount of water, right? So you just set this up, you put it on 20, you put your suction on, the water in here is bubbling, and when we bubble, we want it to be just I don't even know how to describe it. I want to say a normal bubbling, but I don't think that means anything. But we don't want this vigorous bubbling where the thing is like shaking because it's bubbling so hard, right? We just want like a nice pace of bubbling, okay? If that makes sense to you. And we're going to notice that after a number of hours, the water is going to start disappearing, right? And so you come into the room 8 hours later, and your water is now down to here. So this number is actually 17. So if the water is only here, that means that you're only applying 17 centimeters of water suction. And that's not what your provider ordered, right? They ordered 20. So you have to assess and make sure that you are always at that 20. So that means that you're going to have to replace saline, right? You're going to have to replace that saline up here, okay? Okay. I just realized that I keep saying saline. Let me clarify for you. It is not saline. It is sterile water that we are using. I don't know what I was thinking with the saline. I don't mean to confuse you in any way. Please make note that the water suction gets water, but it gets sterile water. It doesn't get water like from the tap, okay? Okay, so that's our water chamber or suction chamber, right? Again, you use your provider's order to tell you how much suction to be applied. So I'm going to want to be clear on this. The amount of suction that you set your wall suction for, or the amount of suction that you set on your portable suction machine does not determine the amount of suction being applied here. So in other words, you could have your suction all the way up on the wall or all the way down on the wall. The suction is regulated by the amount of water that is in this chamber. And again, the most common amount is that of 20 centimeters, or filling up that water to the 20 mark. Now, I'm going to try in some way to explain to you about the dry suction. So the dry suction chest drainage unit is going to look just like this. The difference being there will not be a port at the top to put water into the suction chamber. Instead, down here, there is this dial. And the dial, you turn it to, again, 20. It still gets connected to the suction, but there's no water involved. It is a dry suction. So you use the dial to determine how much suction you want. And again, most likely, it's going to be that 20 centimeters of water suction. Okay, lastly, I just want to go back to the invasive site for a moment and just tell you again that these tubes are sutured in place. They will have a dressing on the site that usually is constituted by a petroleum dressing, which again is kind of slimy and very sticky because it's gauze that is impregnated with Vaseline. And so it's very greasy and it sticks to the skin and it provides that nice occlusiveness right around the insertion site because we do not want any air getting into the patient and causing a pneumothorax. In terms of the dressing, we change those dressings as per hospital policy and whatever your provider wants. Generally speaking, it's a daily dressing change, but you want to, we have that sort of, we have that gauze around the insertion site, and then we put some dry gauze on top of it, and then we use tape, right, to make sure it stays nice and occlusive. So when changing the dressing, we do it once a day. We want to make sure that we maintain that area right at the insertion site, maintain that as well closed as we can. So when we're taking care of patients with chest tubes, a number of things to assess. Certainly breath sounds, right? You're listening to breath sounds. Patients with chest tubes should have breath sounds because that hemothorax or that pneumothorax or that chylothorax is resolving because of the chest tube and the drainage and the suction, right? So you should expect to hear some movement of air on the affected side. Certainly you would expect to hear more air moving on the affected side than you did before they had the chest tube, right? Because when they didn't have the chest tube, their lung was either partially or completely collapsed, right, at that point. So breath sounds would be greatly diminished or absent. But once they have the chest tube, you should be able to hear some breath sounds on auscultation. You want, you want to monitor their oxygen saturation level, right, making sure that they are staying within their baseline or staying above that 95%. You also want to observe their respiratory rate and the pattern. You want to look for symmetrical chest movement. Patients who have a large pneumothorax on one side, that side of the chest may not be moving, right? So those are things that you want to assess. You want to assess the site of insertion for bleeding or signs of infection. And of course, you want to assess your drainage, right? What color is the drainage? What is the amount of the drainage? Is there any change to the amount or the color of the drainage? Now, occasionally, a provider might ask for a specimen to be sent. Now, I did tell you that this whole system was a closed system, right? So how am I going to get a specimen out of this closed system? Well, the manufacturers thought of that as well. If we turn this around, I'm just going to peel apart this plastic here. You're going to see that we have a port here. We also have a port up here. This port up here is actually connected to that water seal chamber. Because remember I told you you're going to put water in the water seal chamber up to this dotted line? What happens if you put too much water in accidentally? How are you going to get it out? Well, you can take a needle and a syringe and you can go into this port right here and you can pull back and get some of that water out of there. Now this port down here is in correlation to our suction chamber. So if you put too much water in the suction, you would be able to suck out with a needle and syringe some of that water. And then the other thing, lastly, is there will be a port for you to obtain a specimen. So remember, this is an aseptic system, right? So you want to clean off that port with alcohol or chlorhexidine, whatever your facility has in their policy. You want to keep your needle and syringe sterile, and you want to put your needle in and pull back on the plunger of your syringe and get some of your specimen, right? And then send it to the lab for whatever it is that the provider wants ordered, okay? These are self-sealing ports, and so you don't have to worry about creating a pneumothorax for your patient or anything along those lines. They are self-sealing, okay? All right, so I think, one more thing to tell you. So these chest tubes come with some handles, okay? And these handles are to be used for hanging the chest tube at the bottom of the bed, okay, or the side of the bed, to make sure that this chest drainage unit always stays below the level of the patient's chest. We never want the chest tube above the level of the chest, because then we're going to get backflow of fluid into the chest. So we use this for keeping the chest tube close to the patient and attached to the bed at the below the level of the chest. The other thing we have at the bottom here is a stand, and this stand, you can turn it so if the patient has to get transported somewhere, you can use your hooks to hook this onto the bed and close up your stand so it doesn't get caught on anything, right? And then the stand is open so that it will be able to stay level on the floor next to the patient, okay? Okay, I think that is it, and you certainly will get a little hands-on practice in lab, and you will get some more information from your clinical instructors. So thanks for watching, and I will see you soon.